All right, let's jump right in. Today, we're tackling the big C in the primary survey, circulation. We're going to break down exactly what you need to do to manage hemorrhage in a trauma patient, all based on the latest from ATLS. Okay, I want to start with a single number, 85%. What is that? Well, that's the absolutely staggering drop in deaths from bleeding in the arms and legs that the military saw once they started using tourniquets widely. It's just a perfect, powerful reminder that the simple things we do, when we do them decisively, save lives. Period. So, in the world of trauma, there's one main villain we're always fighting, and that's shock. The real danger here is that it's a silent killer. It's this state where your tissues just aren't getting enough oxygen, and it can be super subtle at first. That makes spotting it early absolutely critical. So what is shock, really? You can get bogged down in definitions, but it boils down to this. The body's cells are starving for oxygen. That's it. And when you've got a trauma patient in front of you, you can bet the most likely reason for that is they're bleeding somewhere. Okay, so let's get into the nitty-gritty. Your first job, and honestly your most important one, is to see those subtle signs of shock, way before your patient starts to crash. Think of it this way. Everything that follows, every action we take, it all hinges on this one thing, recognizing the problem early and accurately. You have to be the smoke detector, not the fire alarm. You've got to see it coming. All right, let's talk about a really common and frankly dangerous myth. You see a patient, you're worried about shock, so what's the first thing you look at? The blood pressure, right? But is that really the first sign? No, absolutely not. Let me be super clear about this. Hypotension is a late sign. It's an ominous sign. If you are waiting for that blood pressure to drop, you are already way behind the 8 ball. A healthy person can lose a massive amount of blood, like 30% of their entire volume, before that number on the monitor finally starts to tank. So forget staring at the blood pressure cuff for a minute. Your best tools are your own eyes and your hands. You've got to be on the lookout for these earlier clues, the signs that the body is working overtime to compensate. Things like a fast heart rate, breathing a little too quickly, their skin feeling cool and clammy, maybe they're just a bit anxious or confused. Those are your real first clues. Okay, so you've picked up on the signs. You're thinking, shock, now what? The clock is ticking. Your next move is to find out where all that blood is going. You have to find the leak. And this can't be random guesswork. You need a system, a mental checklist. Where can a person bleed enough to die? You have to run through the possibilities fast. Let's break it down into 2 simple buckets. This really helps guide what you do next. You've got compressible bleeding, the stuff you can see and put your hands on to stop, and then you have non-compressible bleeding, the scary stuff that's happening deep inside a body cavity where you can't get to it. And here's a great way to remember where to look for that hidden internal bleeding. On the floor and 4 more. On the floor is the external stuff, the blood that's literally pooling on the stretcher. But then you have to think about the 4 more places inside. The chest, the abdomen, the pelvis, and those big long bones like the femur. It's your quick and dirty checklist for finding a life-threatening bleed. All right, you've found the source, or at least you have a really strong suspicion. Now it's time to act. Priority number 1 is stopping that bleed, as fast as you can, as effectively as you can. This is it. This is where you, with your own hands, can literally save someone's life. The goal could not be simpler. Stop the blood from coming out. So for that compressible bleeding, the stuff you can see, there's a clear game plan. Step 1, direct pressure. Push hard right on the wound. If that's not cutting it for a deep wound, you pack it. And for a limb that's bleeding badly, do not hesitate. Go straight for the tourniquet. Go high and tight. Remember that 85% number from the beginning? That's the power of the tourniquet right there. Now, what about that internal bleeding? A shattered pelvis can be a huge source of hidden blood loss. And that's where a pelvic binder comes in. It's a game changer. By squeezing the pelvis back together, you're essentially making the bucket smaller, so there's less space for it to bleed into. It's a simple move that can be totally life-saving. Okay, so you're working on stopping the bleeding. Now, at the same time, we've got to start thinking about replacing what's been lost. But here's the thing. It's not just about dumping in fluids. How we do it is just as important as that we do it. This is your 4th step, replace. But again, resuscitation is not just about pouring water into a leaky bucket. It's about intelligently restoring that circulating volume to make sure the brain, the heart, the kidneys get the oxygen they need, and crucially, without making things worse. Okay, I know this looks like a physics lesson, but stick with me because this is super practical. Poiseuille's law basically tells us how to get fluids into a patient as fast as humanly possible, and it all comes down to the size of the pipe. And here's the simple takeaway from that law. You want high flow, you need a short, fat catheter. Think of it like a fire hose versus a garden hose. Two big, short peripheral IVs in the arms will absolutely crush a long, skinny central line when it comes to volume. So in trauma, remember this: short and wide is the name of the game for IV access. But what are we putting in those big IVs? This is so important. The old way was just to hang bag after bag of salt water or crystalloid. But we now know that can make things so much worse. It dilutes out all the patient's clotting factors, so they can't form a clot, and it makes them cold. And a cold, coagulopathic patient is a patient that's going to keep bleeding. Which brings us to the final and maybe the most important question you have to ask yourself. When you're resuscitating this patient, are you actually replacing what they lost? They aren't bleeding salt water. They're losing whole blood with red cells, plasma, and platelets. And that's the whole idea behind modern resuscitation. We want to give back what was taken. So ask yourself, are you just filling the tank, or are you truly replacing the very components that sustain life?